Welcome to the second part of sonoanatomy of the peripheral nerve system. In the next hour, I want to show you some nerves of the groin and the lower extremity. We won't manage to do all of them, of course. The time is too short for that, but just a few ones. So this is our beautiful world. And when we want to see Innsbruck, my hometown, it's really tiny here, and you won't find it for the first view. But perhaps you know the region. You know you have to search anywhere in Europe. Perhaps you have heard from Austria. And then we have some landmarks. Our capital Vienna, and famous towns in our neighborhood, Munich, Zurich, or also Zagreb, the capital town of Croatia in our neighborhood. And so we have some landmarks, and when we know landmarks, they are surrounding our point. We can see this small point, this small red dot, Innsbruck, easier than before. So this is the same in nerve sonography, in the peripheral nerve sonography. When we want to see tiny nerves in our body, we have to know where we have to look, and we have to know the landmarks, which help us to find the nerve we want to see. So this is the menu for the next hour. I will show you as an amuse-gueule, the border nerves, the iliohypogastric and ilioinguinal nerves. Then some nerves as starters you probably know already, the femoral ischiatic nerve, and then tibialis and saphenous nerve. As main dishes, something which we often have in our daily routine. The lateral cutaneous femoral nerve, which is often asked to get infiltrated in myalgia paresthetica. The sural nerve after surgery, and the lateral and medial plantar nerves. They are not that often asked. And for the end, some recommended specials, the pudendal and obturator nerve. So this is the lumbar plexus, and this is a huge web of nerves that emerge that plexus. And the most of the ventral nerves of the lower limb come out of it. So the first two ones, the iliohypogastric and ilioinguinal nerve, they emerge the plexus dorsal of the psoas muscle and then run on the surface of the quadratus lumborum muscle ventrally and in a slight obliquely course. And then they pierce, that's important, they pierce the transverse abdominis muscle and run in the abdominal wall ventrally, and that's the point where we can find them. So external landmarks, they are important to know where to put the probe for the first contact. We can see in the most patients, in some of them we have to palpate the anterior supra iliac spine. It's easy to find. And then we go 2 to 3 cross fingers proximal and dorsal to the spine. Put the probe in a perpendicular approach on the iliac crest. You see the lateral edge of the probe should lie on the crest. And then we get this picture. And now we can define our internal landmarks. This is the high echo from the iliac crest and the 3 layers of the abdominal wall. And they are important. The deepest one is the transverse abdominal muscle. Then we have the internal oblique and the external oblique muscle. And the space between the transverse and the internal oblique, this is the important space where we have to search the nerves. And then you see here those tiny nerves in a cross-section area, the ilioinguinal near by the iliac crest, and in the direct neighborhood, the iliohypogastric nerve. We could also see in this layer the subcostal nerve. So the iliohypogastric nerve has 2 end branches, and we could also search them. They are sometimes asked after surgery when patients feel pain in the lateral area of the flank. And once again, the external landmark is the spine. It's easy to find. Now we have to go dorsally a little bit more, just 2 to 3 cross fingers, a little bit cranial to it. Put the probe once again in the transversal approach, the lateral edge on the iliac crest. And then we have this picture. Oops, sorry. The high echo of the bone. Then the 2 layers here are only 2 layers because we are very laterally. The internal and external oblique muscle. Over it, there's just subcutis. And the point of optimal visibility, where we can find this lateral cutaneous branch, is where it pierces the external lamina of the external oblique muscle. And we can see here this cross-section area of the nerve. When it runs forward in a subcutaneous course, but here's usually very hard to see. The other end branch of the iliohypogastric nerve is the median cutaneous nerve. And the external landmark here is not that easy to find. It's the superficial inguinal ring, which you can palpate. In men, it's helpful to ask the patient to cough, then you can feel it better. And then you put a probe on the skin a little bit proximal and lateral to the inguinal ring in a slight oblique position, as you can see it here. And then you get this picture. And of course, we're in the same region. Once again, the internal oblique abdominal muscle is one of the important internal landmarks. The other one is the rectus abdominis muscle. It's always easy to find. It runs straight downwards. So this is the region where we have to search. And important is this region between those muscles. The best point to see the nerve is in the fascia of the internal oblique abdominal muscle, as you can see it here. Here's the fascia, here's the border of the muscle, and this is the cross-section area of this sensory nerve. So let's go over to the starters. Something we have heard often of is the femoral nerve, a big nerve. And he exits the pelvis it runs under the inguinal ligament here. In the lacuna musculorum, this room under the inguinal ligament is divided by this iliopectineal arch in the lacuna musculorum and the lacuna vasorum. In this lacuna musculorum, there's the femoral nerve, the lateral cutaneous femoral nerve, and the iliopsoas muscle. And when we see this, it's easy to define our external landmark. It's the femoral artery. We all know where it is. Usually, you don't have to palpate it. In slim patients, you just take the probe and put it in the region where we, as doctors, should know that the artery is. If the patient, if it's not that easy, just try to palpate and you feel the pulsation of the artery. Like this, and then you put the probe a little bit lateral to the artery on the skin in a transversal approach, and then we see this typical picture. I think we all have seen it yet. The femoral artery, here's a little bit of pressure with the probe, so the vein is compressed, and this hyperechogenic band over the vessels, this is the inguinal ligament. We have here the psoas muscle, so this is the lacuna musculorum, and usually the nerve is lying direct in the neighborhood of the vessels. You can see here this honeycombing pattern of a typical cross-section area of a nerve. And this is a special patient. This nerve is separated by a small artery in a smaller superficial part and a deeper, bigger part. As a variation, it does not have to lie in direct contact to the artery. You could also find it a few centimeters lateral to it. What I have to say, you just have to search directly under the inguinal ligament because the nerve is dividing very quickly in its end branches and you won't see this main stem for a long distance. So the next one the the sciatic nerve, nervus ischiaticus, the biggest nerve in our body. It's really easy to find. I will show you two heights where we can see it to the anatomy. It gets its fibers from L4 to S3, and then exits the pelvis through the foramen ischiaticum, through the infrapiriform part of this foramen. It runs under the piriform muscle, usually. And then over the gemelli and the obturator internus. And what's important, or an important muscle for sonography, is the quadratus femoris muscle. It continues through the dorsal part of the flexor muscles under the hamstrings, straight downwards to the popliteal fossa. So, the external landmarks, they are also to find very easily in most patients. The greater trochanter and the ischial tuberosity. And we have this line between those external landmarks. We put on the probe. Here, you can see here we use for this usually a curved probe. We need the penetration of the lower frequencies because it's deep. And then the medial end of the probe should lie on the tuberosity. And then you get this picture. The big muscle in the superficial aspect of this image is the gluteus maximus muscle, a huge muscle. And as a bony structure, our internal landmark, the ischial tuberosity. And then this is what I told you, the quadratus femoris muscle. It has usually a lower echogenicity than the other muscles surrounding it. And here's the point of optimal visibility for the gluteal or subgluteal region of the ischial nerve, and it is this huge hyperechogenic cross-section area. It's easy to find in the most patients, and a very quick approach. So I told you, usually it exits the foramen ischiaticum under the piriformis muscle, but there are some variations. It could be two parts of this sciatic nerve in this region, and it is divided then it could just pierce the muscle with one part, with the higher one. It could be separated by the piriformis muscle, or it could pierce the muscle as a main stem. This is important to know in patients with piriformis muscle syndrome. When you want to do an infiltration, you want to Botox the piriformis muscle, and you should know the anatomy, because when you're going with a needle in this direction and you're going through the nerve, it would be a problem. So the next step downwards is on the distal thigh. Our external landmark is now the gluteal fold. It's also to see very easily. 2 cross fingers distal of the gluteal fold, and then put just the probe in a transversal approach in the middle of the thigh. You can here use a linear probe if it's possible. Otherwise, you have to change to the curved one. You get this picture. The hamstrings, you probably know. So internal landmarks, the most important one is the long head of the biceps femoris muscle, and in the deep, the adductor magnus. And in between those muscles, we see once again this huge nerve. It's easy to find, and you can follow it the whole thigh downwards to the popliteal fossa, to the bifurcation in its 2 branches. As a variation, we could see the whole length of the thigh, 2 nerves lying beneath each other when there's a high bifurcation of this sciatic nerve. So, one branch of the sciatic nerve, the tibial nerve. I think anatomy is clear. It runs straight downwards through the popliteal fossa, in the center of this fossa, and then goes in the deep under the tendinous arch of the soleus muscle and runs in the flexor compartment to the medial ankle, just straight downwards through in between of the muscles. And we search it in the distal third of the lower extremity of the lower leg, and we can palpate, when we don't know where to put the probe, the distal end of the soleus muscle and the flexor muscles, and then once again transversal approach, and we get this picture. Here we can see the bony structure of the tibia, the flexor muscles, the end of the soleus muscle, and the most important internal landmarks for the tibial nerve are the posterior tibial vessels. Here you can see, usually very easy, the posterior tibial artery. When you do your ultrasound without any pressure, you can also see the accompanying veins. When you use pressure, they are vanished. And then in the direct neighborhood, you can see the tibial nerve very quickly, very easy, and then follow it upwards or downwards to find the pathology. So we go a little bit more distally to the ankle, and here we can see the tibial nerve coming downwards. Then a branch exits the nerve before it enters the tarsal tunnel. In the tarsal tunnel, there's a bifurcation in the two end branches. I will show you later. But now we will have a look at this small sensory nerve which exits the nerve. It's the same region as we had before, transversal approach, and we follow just the nerve downwards, looking on this nerve. Here we are more distal, and now we see a hyperechogenic bend. This is the flexor retinaculum. And the tibial nerve, what we saw before, here the artery, and here the abductor hallucis muscle. And then you can see beneath the main stem of the tibial nerve, there are a few small nerves. They are running subfascial, in contrast to the lateral calcanea branches. They are subfascial, they are not in the subcutis, and these are the medial calcaneal branches. Another sensory nerve, the saphenous nerve. It's bigger than you would expect it, and just once again to the anatomy. It comes with the femoral nerve through the lacuna musculorum, and then exits it, runs together with the femoral vessels to the medial aspect of the thigh, enters the adductor channel and pierces it at the distal, in the distal third of the thigh, and comes then to the superficial structures, and on the distal and the lower leg, it runs together with the bigger cephane vein to the medial ankle. The important structure I want to show you is this muscle, the Sartorius muscle, here covering the femoral vessels and the nerve, and we will see now in the pictures that this is our internal landmark. External landmarks, they are not that easy to define here because there are no bony structures. It's just the anterior superior iliac spine and the base of the patella, and we know the course, so it's, where the saphenous nerve might run. We put the probe in the middle third of the thigh in the medial aspect, in a transversal approach, and then we get this picture. And here we see the vessels. They're usually very easy to see, covered by the Sartorius muscle. This muscle usually has a nearly triangular structure here. You can find it very easy. Median to it, it's the median vastus muscle, and here in the deep you can see the long adductor muscle. So these are our internal landmarks, and then it's not that hard to identify this cross-section area of the saphenous nerve. And then you can follow it from this position upwards, downwards, and yeah, that's not very hard. As a variation, it does not have to lie anterior lateral to the vessels. It might also lie on the other side of them. So one step more distally. The first picture I showed you was in this region. We go more distally. And once again, we have the Sartorius muscle as our internal landmark. And now we're at the height of the adductor channel. It is bordered by the median vastus muscle. The Sartorius muscle, here's the vastoadductor membrane. It's an important structure, this hyperechogenic band, and the adductor magnus muscle. So this is the adductor channel, and here we see once again the the cross-sectional area of the saphenous nerve. And now going to the distal third, where it exits the adductor channel, we just take as our external landmark the base of the patella, one hand proximal to the patella and median to the thigh. Oops. In this approach. And it's nearly the same, but now we can see the vastoadductor membrane in the deep. Sartorius muscle lying on it. Here's the median vastus muscle. And then we can see here the nerve now lying just beyond the vastoadductor membrane. It just has pierced the membrane and left the adductor channel. It runs, if you want, as internal landmark, you could also take the Doppler and see if there's anywhere an arterial signal. It would be the arteria descending, the descending genicular artery. It could be one external landmark, internal landmark to find the nerve because they pierce together the vastoadductor membrane. So, main dishes, the lateral femoral cutaneous nerve. As I told you, we often have to assess it in cases of meralgia paresthetica after hip surgery or without any reasons. And it's at the beginning, we started to search it at the iliac spine, at the anterior superior iliac spine. I will show you a point where you can find it more easily and then follow it upwards. So once again to the anatomy. As I told you, it leaves together with the femoral nerve and the iliopsoas muscle through the lacuna musculorum, the pelvis, and then pierces the fascia lata and runs subcutaneous on the lateral and proximal aspect of the thigh. It's a purely sensitive nerve. And in the pelvis, we could also try to see it, but it's not easy and it's not asked very often. So external landmarks, anterior superior iliac spine, it's very prominent here in this region. You go distally a few centimeters, and then you ask the patient to lift the limb a little bit. And then you see a little groove between the Sartorius muscle and the tensor fasciae latae muscle. You can also palpate this groove. You fall with your fingers in it, and then you put here the probe in a lateral, in a transversal approach, just a little bit downwards of the spine. Usually you would search meralgia in this region, but you search the nerve first here. And then you get this picture. Sartorius muscle is our internal landmark. The other one, the tensor fasciae latae, flat muscle. This is rectus femoris. And now you can see this fat-filled flat channel. A structure where often the subcutaneous nerve, they often run in such fat-filled flat channels, and this is a very prominent one. And you just follow those muscles upwards and downwards, and then you will identify this channel. And in the center of these channels, we can find these cutaneous nerves, in this case, the cutaneus femoris lateralis. When you found it there, you can follow it upwards, and then you can see if it thickened at the iliac spine. What's important to know, especially when you do infiltration therapy, there's a high variation in the exit of the pelvis. Usually, it leaves the pelvis median to the anterior superior iliac spine, but it also could go, could emerge it dorsal to the spine and proximal, through the inguinal ligament, even through bony structures that are described, but also a few centimeters medial to the iliac spine. So it's important to know where it is when I want to do an infiltration therapy. And this is a study they did. They did a cadaver study, and on the one side, a blind approach, just by palpating the anterior suprailiac spine. On the other side, with ultrasound, and then they controlled it. And with a blind approach, they had just one of 19 needles had a contact to the lateral femoral cutaneous nerve. On the other side, 17 of 19 needles with ultrasound were in the right position. So I don't know who did it. We would have 19 of 19, of course. But you see this big difference. Ultrasound helps us to do the infiltrations on the right position. Of course, you could use a high amount of drugs, and then you will cover the whole region there. But when you do just when you won't have a lot of side effects, take less amount of drugs, and the ultrasound, so you will be precise and very quick. The next one, sural nerve, also a sensory nerve on the distal leg. It is composed of two branches, the medial cutaneous nerve and the lateral one out of the fibular nerve. They come together anywhere in the middle or distal third of the lower leg. And the nerve runs in between the two heads of the gastrocnemius muscle to the lateral ankle. So we usually try to find it very distally, where the union has already been of these two nerves, then we can follow it upwards. External landmarks are the lateral ankle. We go a little bit upwards, 4 cross fingers. We can feel the Achilles tendon, and there's a groove between those two structures, and we put the probe in a transversal approach again. And we get this picture. Here, the fibular muscles, soleus muscle, distal end, the other side, and we have seen on the medial side. And the important region now is the subcutis. And here we see this small dark spot, the small saphenous vein. And this is our internal landmark. So you have to be very carefully, no pressure at all, because when you press the probe a little bit on the skin, you won't see the vein anymore. And this is our internal landmark. When you find the small saphenous vein, you will find the sural nerve. Here's the fascia of the muscles and subcutis, and in the neighborhood, anywhere, it could be medial or lateral to the vein, there's the sural nerve. When you found it there, just go upwards, then you will see the one branch in the direction to the tibial nerve, the other one to the fibular nerve, and you can follow them very easy. So the distal branches of the sural nerve, they're running to the lateral ankle, as I've told you before. This web around the lateral ankle, the lateral calcaneal branches, we also can find them. So our external landmarks are, of course, the calcaneus and the insertion of the Achilles tendon, the lateral ankle. And here's the problem, of course, the contact. You could use a lot of gel, or you use a gel pad, because otherwise you might have air between skin and the probe, and a big problem. We also have now the hockey stick probe. It's easier with it. It has this small contact, and it's very, very beautiful to do the ultrasound in this region with the hockey stick probe. You just move downwards your probe along the Achilles tendon in this groove, and anywhere here the branches should leave the main stem. So this is the fascia, the muscular fascia, And in contrast to the medial ones, they are now lying really in the subcutis. So we just have to search some tiny little cross-section nerve areas. There are also a few of them, not only one nerve, and easy to find. Just follow them upwards and downwards. And then we go to the sole of the foot, to the medial and lateral plantar nerve, the end nerves of the tibial nerve. I've told you the tibialis nerve divides in the tarsal tunnel in its two branches, the lateral the lateral plantar and medial plantar nerve. They are dividing in its end branches more distally. And our problem and our external landmark, both, is the plantar aponeurosis. External landmark because it's easy to palpate. A problem because it's very dense and it causes blurring when we do ultrasound there. So it's not very good to see the nerves in the deep of the sole of the foot. So I will show you just the pictures proximally. External landmarks, once again, the medial ankle and the tuber calcanei. And we have this line between those external landmarks. We put the probe here, use a gel pad or the small probe, and then we get this picture. Here are the flexor tendons. And now the important structures, as the same as the tibial nerve proximally, are the vessels, the posterior tibial vessels, the artery, the accompanying veins. And here this hyperechogenic structure, the flexor retinaculum. And there we see two cross-section areas of the nerve. It's splitted yet. The medial and the lateral nerve just after the division. As a variation, you could see the main stem going more distally, so a deep division in those two nerves, and you could see in the tarsal tunnel just one nerve. A little bit more distally, the same landmarks, and now the probe in a longitudinal approach. And here you have to press the distal edge in the tissue to get a better image, because it's a dense structures there. The sole of the skin has a thick cutis, and it's the plantar fascia also in this region. And then we get this picture, this image, a lot of muscles, and you have just get orientation, bony structure. So this is the talus, the sustentaculum tali, the long flexor tendons, the short ones, the abductor hallucis tendon. And in the deep, this is the quadrator plantaris quadratus muscle. And the most important internal landmark to my mind is the plantar artery, which we see in the center of this connective tissue space here. And it's surrounded by two nerves, so it's in the middle of two nerves, two cross-section areas. These are the medial and the lateral plantar nerve. You can try to follow them more distally, but the problem is the blurring of the plantar aponeurosis. But in the book, we also have pictures there, but it's we will take time to see them. So we're coming to the end. Recommended specials. The Pudendal Nerve, a nerve I always got scared when I heard I have to assess the Pudendal Nerve. But now I think it's really easy if you remember just one structure. Anatomy once again. So we have had the sciatic nerve yet, and now the carotid Maximus, Gluteus Maximus, and we see a structure here where the pudendal nerves runs under it, the sacrotuberous ligament. And the most important structure you have to remember is the internal obturator internus muscle. External landmarks are once again the ischial tuberosity. You palpate it and you put the probe just 1 to 2 centimeters proximal to it on the skin. once again, a curved probe for the penetration, and you get this picture. So this is the lateral and medial side. You have here the high echo reflex of the ischial bone, and then a structure what reminds us to a waterfall. It's just when you're going upwards and downwards, you see this structure winding around the ischial bone like a waterfall. And then this is our internal landmark. You can use the Doppler, or you see an artery in this region, and proximal superficial from the dorsal aspect, superficial to this artery is the pudendal nerve. Very easy to find and very easy to infiltrate here. I didn't believe Hannes until he showed it me, so it's really a good thing. The last nerve for today, the obturator nerve. Oops, this was too much. So it receives its fibers from L2 to L4 and runs behind the psoas muscle downwards to the lesser pelvis, and then runs through the obturator channel and divides in two branches, the anterior and posterior one. Our internal landmarks are the adductor muscles, as I will show you now. The external one is once again femoral artery, but now in contrast to the femoral nerve, medial to the artery. We can also palpate the long tendon of the long adductor muscle, and then we put the probe in between those external landmarks in a transversal approach, slight oblique. You will see it, how you can see the muscles then in the best view, and then we get this picture with the bony structures of the ischial bone, superior and inferior branch, and in the superficial aspect of the picture, the pectineus muscle, and in the deep, the extern obturator muscle. And the point of optimal visibility is here in between those two muscles, pectineus, obturator externus, and this is the cross-section area of the main stem, proximal, just where it exits the obturator channel. You could also see two nerves here in case of a high bifurcation. When we go more distally, we can now detect the end branches, the anterior and posterior branch. It's the same landmarks, but it's just a few centimeters distally to it. And we get this picture of the adductor muscles. In the superficial one is the long adductor muscle, followed by the short one, and in the deep, the adductor magnus. Don't think that these are two muscles. The adductor brevis usually has this septum in the middle of it, but it's one muscle. So don't think it's just this one. Longus, brevis, magnus. This is what we have to have in mind. Here we see the femoral veins, and the regions where we have to search for those muscles are anterior nerves, anterior and posterior to the adductor brevis muscle. The anterior branch of the obturator nerve runs ventral or anterior to this muscle, the posterior dorsal to it. In this case, we had already a bifurcation of the anterior branch in a small side branch and a bigger one which is running downwards. So I hope I could show you some external landmarks, internal landmarks to find the nerves quick and easy. And now we go over to a live demo.
We can do the questions later. Yeah.
Also, sollen wir, okay?
No, I think there's no immediate questions. No. Okay.
Also, jetzt hänge ich natürlich da. Kannst du mir mal da helfen? Death by cables. So. Ja, so ein bisschen ausstrecken. So, gerade das Ausstrecken ein bisschen so, genau. So we will see the big nerves first. Femoral nerve. So what's our external landmark? I think we've heard it a lot of times now. What would you search? femoral artery, you could try to palpate it, but usually it's easy to see in an ultrasound picture. The vein is vanishing when I press a little bit, and here we go upwards, inguinal ligament, the femoral artery, the pulsation, and then we're searching for a usually triangular structure. You can see here the femoral nerve lying beneath the vessels. When we go downwards, it vanishes because there are a lot of small branches coming out of this huge nerve. The lateral cutaneous femoral nerve, we would just ask the patient to lift the limb a little bit, gerade ein bisschen anheben das Bein, and then we see and feel this groove here. Can you see it? No. It's getting tired now? No? Geht's noch ein bisschen? Here is this groove. I can feel it. Dann wieder hinlegen. And then you put the probe here in a transversal approach. We see here the Sartorius muscle. Anyway, here the tensor fasciolate, and here's this fat-filled flat channel. And in the center of the channel, we see here already a division. Here's a small side branch, and here's the main stem of the lateral cutaneous femoris nerve. I'm now going upwards a little bit, and you see the internal landmark, the Sartorius muscle, and it's running on the, here's flattened, and on the muscle upwards to the, now I've lost it, once again back. There, here you can see the nerve. It's very flat here. There are a lot of fascicles running beneath each other. And upwards to the, here's the spine. And the exit of the nerve is here. So it's easier to find it in this position than at the iliac spine, anterior superior iliac spine. So now we are searching for the saphenous nerve. You just have to ask the patient to lie in an external rotation just a little bit. Then in the medial third of the thigh, we put the probe on the skin, and then we can see falsche Richtung, so, the triangular structure of the Sartorius muscle. And here in the deep to it, the femoral artery and the vein, and lying beneath the artery here, the saphenous nerve. So we can follow it upwards or downwards. Now we're going to the distal third, and here we saw the arteria genudescendens, piercing the vasoadductor membrane here, in this position, and here also the nerves pierces the membrane, as you have seen it yet. And here is a small branch which we could follow to the knee. It's the infrapatellar branch of the nerve. Once again, here the vessels, Sartorius muscle, and then it's not very hard to find the saphenous nerve and follow it downwards. Here's the nerve after the penetration of the vasoadductor membrane. Gut. Then, was machen wir denn? Die border nerves. Gerade da oben ein bisschen fein machen. So, external landmark for the border nerves is in this region is always one external landmark, the anterior superior iliac spine, which we can palpate or of course see in slim patients. We go a little bit proximal and dorsal of the spine, and then we put the probe in a perpendicular approach to the iliac crest, and then we can see those three layers of the abdominal wall: the transverse abdominal muscle, the intern and extern oblique muscle, and then here's the iliac crest, and beneath the crest there are two cross-section areas. Here's one, and here's the other one, the ilioinguinal and iliohypogastric nerve. You could try to follow them distally. They are sometimes injured in post-operative problems, but to find them, you just have to look here on the proximal to the iliac spine, where these 3 layers are really easy to see. 1, 2, 3. So then we turn around, please. Jetzt gerade die Unterhose ein bisschen aufziehen, genau. So, then we change to the abdominal probe or curved probe. So, external landmarks, the ischial tuberosity, just try to palpate it, or you can see here the bony structure. The big muscle in the superficial aspect of the image is the Gluteus Maximus muscle, in the deep, the quadratus lumborum, and here in between the sciatic nerve. It's easy to find here. And in this region, we also can have a look at the pudendal nerve. And this is the structure I've told you, this waterfall sign. Here, around the ischial tuberosity, just a little bit proximal to it, and you see this dark muscle, the obturatorius internal muscle, and then we can try to get the pudendal artery. No? No? Was ist los? Just a moment. We don't see the pudendal artery. Ah. No. It has to be in this region. And here's the nerve, the pudendal nerve, just beyond the artery. Now we had the signal. Here you can see the cross-section area of the nerve. It's always next to the obturator internus muscle and easy to find. And when you do an infiltration, you have an approach from the lateral side in this direction, and it's very easy, very quick. Here's the nerve. So the sciatic nerve on the thigh, very easy to find. Just put the probe in the middle of the thigh, just a few centimeters distal to the gluteal fold. And then we have the long head of the biceps muscle, here, other side. No, this is the adductor muscle, semitendinosus and semimembranosus, and here the long head of the biceps muscle, and in between this huge nerve, you can also have a longitudinal view of it, the sciatic nerve, and we can follow it downwards, just in the center of the thigh, when we have enough gel. Straight downwards, and anyway, here we should see the bifurcation in the 2 branches. That's I will want to change to the 14 megahertz probe. It's easier to see with a higher frequency. So here, this huge nerve, long head of biceps muscle, adductor magnus, and here the nerve. We're coming in the near of the popliteal fossa. And this is already here's the bifurcation. Do you see it? Here's one prominent fascicle in the fibular branch. And here we have, it's hard to see because there's curvy course of the nerve, but here we can see very good this bifurcation in the fibular and tibial nerve. Fibular nerve goes to the lateral side of the knee, and the tibial nerve runs straight downwards with the vessels through the popliteal fossa. Here's the nerve, and then with the under the tendinous arch of the soleus muscle, which is here. This one. So just the center of the distal thigh. Here's the tibial nerve. It's descending here in this region from the center under the tendinous arch, and here it's really it's not that sharp. Then we can see it in the distal thigh, but here it's the artery, the pulsation of the artery, and here the tibial nerve lying beneath it. And this is the arch, and here it goes under this arch. Distally. Jetzt müssten wir wieder umdrehen, bitte. Hast du about it, huh? Gerade so ein bisschen nach außen drehen. So. A slight external rotation. We have the inner ankle, the Achilles tendon, and here this groove between those structures. We put the probe in a transversal approach. And then, kann ich das ein bisschen näher haben? And here we have the tibia, the muscles, the flexor muscles, soleus muscle, and in between the pulsation of the dorsal tibial artery. And here, next to the artery, we can see this beautiful cross-section area of the tibial nerve. You see the veins, they are vanishing under pressure, artery and the nerve. We can follow the nerve now in the tarsal tunnel. Here's the flexor retinaculum, always in the neighborhood of the posterior tibial artery. And here we have already the bifurcation of the tibial nerve in the median and the lateral plantar branch. When we want to see the medial calcanea branches, we just have to scan the nerve and see when small branches leave it. It's here, one branch. And there are subfascial. Here's another one. You see this small bubbles running under the retinaculum, flexor retinaculum. So just turn inside a little bit, and we will search the Suralis nerve. Vielleicht einfach ein bisschen ganz auf die Seite drehen. So, ja, so ist super. So, proximal of the lateral ankle. Anywhere there has to be the small saphenous vein, but it isn't here. Da. Jetzt muss man nochmal bitte auf den Bauch drehen. It's easier to turn the patient on the stomach. Tut mir leid, bist du noch voll gel, gell? In the distal third, and here we see an interesting vein. Is this the vein? This one. It seems this must be the vein. Die ist verstopft. Hast du mal ein Problem gehabt? No? No, Ella? Here it's open, as you can see it. So I've really, I just have slight contact. Now, it was too much pressure. And we see the vein. And next to the vein, here the sural nerve. This one. It's easy to find in the neighborhood of the saphenous vein. Aber ganz normal. Yeah. Okay, I think that's it.